Good afternoon. We'll now start. So first of all, I'd like to welcome everybody to this pep talk this afternoon. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Please include the names of your companions attending with you. Use the chat box to ask questions and make comments while the pep talk is on. There will be group pictures at the start and at the end of the pep talk. As a reminder, please take the online learning kung evaluation test exercise for mastery of learning and have a perfect score to get a certificate like the one shown below here. The link, I already placed the link in the chat box. Another reminder, 50 OLETE certificates will entitle one to a voucher of ROJoson telemedical consultation. We are now on our 57 or 58 pep talk already. Another request, those who are not planning to take the OLETE, where I ask for feedback, please type in your feedback in the chat box during the open forum and before we close the sessions. So let's now have a group picture taking before we start the pep talk proper. Okay, ready? Everybody ready? 1, 2, 3. Okay. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I've been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Thyroid Test Results. Thyroid Test Results, Reading and Interpretation. This is part of the health issue course. The empowerment objective is for the lay people to have an understanding of the importance of reading and interpreting thyroid test results in their health management. The contents of today's pep talk will be the following: general recommendations on reading and interpreting lab tests with numeric values and narrative descriptions and conclusions, how I read and interpret thyroid test results, idiosyncrasies of the radiologist in reading and writing thyroid ultrasound results, examples of challenges, and then my advice in reading and interpreting thyroid function tests and thyroid ultrasound. Thyroid function tests and ultrasound of the thyroid are commonly done as laboratory diagnostic tests for patients with possible thyroid disorders. A lot of Filipino patients have this test done for one reason or another, usually resulting from a screening fad or ordered by physicians who are considered to be ritualistic and maximalist. Then they ask me, when I say they, a lot of these Filipino patients ask me to read and interpret the results. I have to divulge that I am a minimalist physician. I don't subscribe to the screening fad of lay people, as well as physicians who are usually ritualistic and maximalists, and who outrightly want to please their patients with their desire for screening laboratory tests, even without valid indications. I do laboratory tests only when indicated. Examples would be patients with symptoms and signs which I am not very definite of with my diagnosis, that I need some help from laboratory tests. Patients, another example would be patients without symptoms and signs, but with a high risk for a particular disease. So that's another indications for the lab test that I usually do. In my practice, I cannot avoid or refuse patients coming to me for interpretation of the results of their lab test requested by themselves or other physicians. And because of the prevalence of these events, I have decided to write something about them, particularly to advise the lay people on how to read and interpret the results of lab tests. For today, I will focus on thyroid. Last week, we tackled breast ultrasound, and mammography. I like to empower the patients to know the principles and processes and caveats of reading and interpreting lab results, so that along the way, hopefully, I can convince them to have lab tests done only when indicated, kung kailangan lang. Before I go to the thyroid test, allow me to give you some important, relevant introductions. So the topic here is thyroid lab tests concerning the thyroid. So the thyroid gland, as a review, is a butterfly-shaped organ located in the base and central neck of the neck, as illustrated in this picture. The thyroid gland is a vital organ. When you say vital organ, it's one that is needed to survive, that regulates metabolism, growth, and development of the human body. The thyroid gland makes, releases, and controls thyroid hormones that control metabolism. Metabolism is a process where the food is taken into the body and then transformed into energy. So this energy is used throughout the entire body to keep many of our body's systems working correctly. If there is an abnormality in the thyroid gland, the commonly used term is goiter. Thus, there is a goiter when there is an abnormality in the thyroid gland. The abnormality can be in both structure and function, both singly or in combination. So there could be abnormality in function, and which is usually represented by hyperthyroidism and hypothyroidism. If the thyroid function is normal, we call it euthyroidism. Euthyroidism. Abnormality in structure is another abnormality that can be seen in the thyroid. No, it's usually present as either enlargement or nodule or mass formation. So once you have the enlargement or there's a mass, we call that abnormality in the structure. So the other situation is that you can have a combination of abnormality in both structure and functions. The usual thyroid function tests being done nowadays, especially in the Philippines, are the FT3, which stands for free triiodothyronine, FT4, free thyroxine, and TSH, or thyroid stimulating hormones. The thyroid function tests are diagnostic tests for thyroid function. It can determine whether you are in the euthyroid, meaning normal function, thyroid function, or you have a over-functioning thyroid gland producing hyperthyroidism, or underperformance of a thyroid gland, which is called hypothyroid. Kulang naman, hypo. Okay? The usual interpretations of thyroid function tests are the following. Okay. Normal is the diagnosis will be a normal thyroid function if you have normal FT3, normal FT4, and normal TSH. Okay. So as I said, the term here is euthyroidism. If all these three are normal, then you are euthyroid. Okay. Now, if the T3 and T4 are elevated, and then there is depression of the TSH, then you have hyperthyroidism. Okay, notice the baligtad ito na elevated and then depressed. It's okay. Take note of that findings that can lead to the interpretation of hyperthyroid. Sa hypothyroid naman, mababa ang T4 and T3 pero mataas yung TSH. Okay? TSH is the one stimulating the thyroid. Kaya kung mababa ang thyroid hormones being produced by the thyroid gland, there's a automatic regulatory system in which tataas ang secretions ng TSH para to compensate, trying to compensate para dagdagan itong FT3 and FT4. Okay. So there are, when I say normal, elevated, depressed, there are reference ranges, meaning normal values for the different types of thyroid function tests. I will not put the normal values here because yung mga normal values vary from one laboratory to another. Okay. Then these reference ranges have numeric values. May mga numbers yan. Hindi siya description. Okay. So here I have placed down a note. This must be correlated clinically. Okay. Meaning you have to check the symptoms and signs to be able to finally conclude whether it is really normal, hyperthyroid, or hypothyroid. But initially, you can look at the results, okay? But to validate whether it's really hyperthyroid, hypo, or euthyroid, you must take a look at the patient's symptoms and signs. Okay? So if there are incongruencies, when you try to correlate the symptoms and signs with the values, with the thyroid function test values, if there are incongruencies, may mga contradictions and may doubts, then a clinician would just have to repeat the test. Another situation that are commonly seen will be, ito, normal pa rin, normal lahat, normal, so normal thyroid function test, no? And then if the patient does not manifest symptoms of hyper or hypothyroidism, tatanggapin na lang natin ito as the result. Okay? But there are instances in which there is the FT3, FT4 are normal, pero yung TSH depressed. Okay? In this particular instance, most doctors, most clinicians will label this as hyperthyroid, okay? Because they put more importance on the TSH. No? Okay. Now, in another situation, normal FT4, FT4 and FT3, but elevated TSH. As I said, most of the clinicians put a lot of importance on the TSH. So if it's elevated, it's still hypothyroidism. Okay. But again, a caveat here will be these laboratory results may be wrong. Okay. And then so you have to correlate it with the clinical findings in terms of symptoms and signs of the patients. So if there is really symptoms of hyperthyroidism and then depressed ang TSH, tatanggapin natin yung results. Okay. If the patient manifests with signs and symptoms of hypothyroidism and elevated TSH, then we accept the results. Okay. Pero kung wala siyang signs and symptoms of hypothyroidism or signs and symptoms of hyperthyroidism, if these are the results, then it might produce some doubt. Then one option is to repeat the test. Okay. So challenges in the interpretation of thyroid function tests. I will cite you a particular patient. Okay. 66-year-old female had thyroid function test done as a screening. As I said, I don't usually order these things unless it's really indicated. So it was ordered by somebody else. There were no symptoms of hyperthyroidism or hypothyroidism. So she got these results. Okay. FT3, okay, 2.54. So it's below the range. 2.73 ang lower limit, no? Pero sa kanya 2.54 mas mababa, so low. Then FT4 normal siya, di ba? Normal, okay? but the TSH is high. Okay, 7.01. Ang upper limit nito is 3.75. Okay, so medyo because of my vigilance against laboratory errors, no? So I asked for a repeat. So pina-repeat ko ito. So about 1 week, 2 weeks after, okay, the repeat thyroid function test showed everything to be normal. Okay, normal FT4, FT3, and normal TSH. Okay. So the challenges here, the dilemma, okay, but this was caught by a clinicians. Okay, if there were no repeat tests, patient would have been treated unnecessarily with medications, which can be lifetime. Okay, in this particular case, mababa ang T3 niya, mataas yung TSH. So hypothyroid ang interpretation ng ibang doktor. So she might be treated with hypothyroid and given medication for life. Okay, so she will have, if no repeat test were done, okay, she will have an unwanted lifetime anxiety of thinking, I have a thyroid disease. Forever may ingrain sa utak niya, no? Okay. Although she may have, sometimes they can have a cascade of other unnecessary tests. Ito, we don't have any choice but to repeat just the test, okay? So sometimes some doctors would go for ultrasound and then biopsy that may be needed to do further investigations, okay? That is what is meant by cascades of other unnecessary tests, okay? Fortunately for her, a repeat test has prevented these errors and also a possible negative consequences. Another type of error, kanina hypothyroidism, pwede ding kabaliktaran, hyperthyroidism. So the error in interpretation of hyperthyroidism based on a decrease naman yung TSH without symptoms, okay? And then, if you repeat it, sometimes you repeat it, it will turn out to be normal. So let's say the repeat test showed normal results. So if not rechecked, patient could have been treated erroneously for hyperthyroidism. Again, usually lifetime yan. And then the diagnosis of hyperthyroidism will be ingrained into the mind of the patient that he has a thyroid disease. Yun pala normal. So let's now go to the ultrasound of the thyroid. Okay. So ultrasound of the thyroid, yung thyroid function test, mga numeric values yon, na mga numbers. But for the thyroid ultrasound, this contain narrative description by the ultrasonographer or radiologist, okay, and then also some conclusions, okay. So it's an ultrasound of the thyroid. No, as I said, ultrasound of the thyroid is a diagnostic test for structure, whether it's enlarged or there are nodules. And if there are nodules, is it benign? Is it not cancer or is it cancer? Okay. So what one can see in the possible scenarios on the ultrasound findings, ultrasound with the thyroid will be enlargement. Malaki lang yung thyroid gland. Okay, both lobes. Okay, pero walang bukol. That's one scenario. Another scenario, enlargement, malaki, pero may kasamang bukol. And then, another scenario is mga bukol-bukol, marami o isa. Okay, how many? Location, right, left, isthmus, etc. And then, usually they measure the size and then the nature, whether it's cystic or solid or complex. Cystic means it contains fluid, solid, no fluid. Complex means a combination of fluid and solid element. And then border of the nodules, whether it's distinct or indistinct. And then a lot of times the ultrasonographer also give the ratio between whether the tallness and the wideness of the mass. Okay, and then they also describe whether there are calcifications or not. Okay, and then the other finding that you can see, that you can discern in the ultrasound, will be whether there is or there is none. Okay, enlarged thyroid neck nodes. Okay, these are also important in the diagnosis. Ito yung mga usual conclusions nowadays, okay, that are being done by radiologists. They're starting we're starting to have a lot of this already. Okay. Last time we talked about THYROIDs sa breast by B. This time it's THYROIDs T. T stands for thyroid. Thyroid imaging, reporting, and data system. But this thyroid, when they report thyroid, it's only for nodules. Okay. Yung mga nodules ang nakikita doon sa ultrasound. Okay. And then on the basis of these thyroids, no, it will determine whether there's an indication to do needle biopsy. Needle biopsy. Okay. So the thyroids is 1, 2, 3, 4, 5, 6. Doon sa BIRADS may 0, pero dito walang 0. Na? Okay. So, pag thyroids 1, it means negative, or based on ultrasound findings, normal ang thyroid. Thyroids 2, benign. Okay. So, may benign features. Okay. So, example of benign features, walang may cystic component, something like that, and also the nodules are well defined. Okay. Thyroid 3, probably benign, without suspicious features, probably. Okay, so hindi siya 100% pa rin, probably. Then 4A, 4B, 4C, low, intermediate, and moderate. Okay, and then high suspicion, thyroid's 5. Okay, so you can see here, pag may one suspicion feature, they call it low suspicion. If there are two suspicious features, then 2. 4B, intermediate, 3 or 4 suspicious features, 4C. Kung 5, high suspicion. Okay. So you can see, medyo may konting subjectivity dito, but there's a basis. But kuminsan nakakalito rin. No? So 1, 2, 3, or 4, or 5. Okay. Yan ang basis for saying thyroids 4, A, B, C, and 5. So here is another classification that they use. Okay, they give points, 0 points, 1 point, 2 points, ganon. And then they add the points together, no? Mga features of ito, whether cystic or solid, height kung maraming echoes or not, and then taller than wide, and then border, whether ill-defined or well-defined, and then kung echogenic focus, kung may mga foci, calcifications, then they use points. Okay, yeah, add mo lang yung mga points to come out with the conclusion whether it's benign, not suspicious, mildly suspicious, moderate suspicious, highly suspicious. And here they have recommendation: no needle biopsy is needed for benign, no needle biopsy for thyroids 2. Okay, ito starting with mildly suspicious 3, 4, 5. Okay, kailangan na ng recommendation is to do a needle biopsy. So now I like to show you a method that I use to diagnose thyroid disorder without the use of ultrasound and thyroid function test. Okay, so when I see there's an enlarged thyroid gland on palpation, okay, without symptoms of hypothyroidism and hypothyroidism, I give out the diagnosis of diffuse colloid adenomatous goiter. And then if there's an enlarged thyroid with symptoms of hyperthyroidism, like sudden weight loss, palpitations, increased heart rate, and then bulging eyeballs, no, I give a diagnosis of hyperthyroidism. If there's an enlarged thyroid gland with symptoms of hypothyroidism, like edema, slow movement, then I make a diagnosis of hypothyroidism. But again, all of this should be correlated with the clinical findings. Okay? So here I'd like to share with you my experience with the clinical diagnosis without the use of thyroid ultrasound and thyroid function test. I'd like to tell you honestly, modesty aside, my batting average is more than 90% accurate, just based on this algorithm. Now, with multiple thyroid nodules, marami, more than one, but with no signs of malignancy, then my diagnosis would be multiple colloid adenomatous goiter. I will tell you later on what are the clinical signs of malignancy here. Now, if it's cystic complex, I call it colloid cyst, colloid adenomatous nodules. And if it's solitary or multiple nodules, but with signs of malignancy, then I come out with a diagnosis of thyroid cancer. Okay. Now, the clinical signs that I use to get a clue on the malignant tumor of the cancer would be the following. It's hard. The nodule, if the nodule is hard, but it's not due to the calcification. Mga calcification kasi yung mga calcium deposits yan, kamisan matigas yun. Yung mga, especially with those with long-standing thyroid goiter, matigas talaga yun. No? So, but if it's not due to the calcification, if it's talagang matigas, then I suspect cancer. Then with signs of invasion, yung nag-encroach sa surrounding tissues, causing fixation, hindi siya gumagalaw na, and then kumisan, na-encroach dun sa nerve, causing hoarseness of voice. So if you have fixation and hoarseness of voice, that's a sign of that. Those are signs of malignancy. And then if there are signs of spread to the neck nodes and as well as to the distant mass, let's say to the bone, to the lungs, then I suspect malignancy. So these are the clinical signs of malignancy that I use. No? So if there are solitary nodules with signs of malignancy, I suspect thyroid cancer already. Okay. So my options here will be either needle biopsy first or outright operation. If I'm more than 90% or 99% certain based on the clinical grounds that it's cancer, I operate already right away. Now, if the degree of certainty is below 90, I can do needle biopsy first. Okay. So the challenges in the THYROIDs, okay, there are a lot of overreading, okay, overreading, leading to a lot of needle biopsy. So that's the downside of this new development. Okay. So illustration 1 on the THYROIDs, again, 66-year-old female. In 2016, my clinical diagnosis was multiple colloid adenomatous goiter. My basis was that there were multiple nodules, but with no signs of malignancy. So I have been following her up for 6 years with the same diagnosis and with no biopsy, just checkup, okay, monitoring. But one day in 2022, she went for an ultrasound on her own. The reading was thyroid 5 for one nodule. Okay, there were several nodules, but yung one nodule was read as thyroid 5. And then without consulting me, she had herself biopsied, and then it showed adenomatous nodule. So I told her I was right after all, okay? Because in 2016, my diagnosis was colloid adenomatous goiter. So this was the picture of the results of the ultrasound. So you can see here, right thyroid lobe mass, thyroid 5, okay? The finding was that if it compared to the 2017, there was no significant change in size, but just the same, it was read as thyroid 5. And then the recommendation of the ultrasonographer is that a biopsy is recommended. Okay. So here at tiny cyst, it's a benign one. No cervical lymphadenopathy, no lymph nodes. Okay. So these are, okay. Several nodules. Okay, one nodule was selected and then read as thyroid 5. So this caused anxiety on the patient, and then she had herself biopsied. Okay. So another patient, okay. So you can see here, multiple nodules and dami, no? Okay. So a combination of thyroids 3, bawat nodule binabasahan nila ng thyroids, no? Okay. So ito, hindi siya nabasahan ng thyroids, but spongiform, when you have spongiform nodules, parang cystic na rin yan. So it's benign, okay? And then this one, complex, predominantly solid nodules, kaya thyroid 3, complex, as I said, cystic, complex, okay, usually benign siya, no? And then, ito, well-defined border, pero Pinasahan siya ng THYROID score. Okay? Because of the increase in size. No? 2.1, previously 2. 1 point. Well-defined border. Okay. 2.7, 1.6. Previously, mas maliit. Ewan ko kung bakit siya nabasa ng THYROID score. Okay. Okay. Well-defined naman yung margin. No? Okay, baka itong internal echo. Okay. And then this one, another nodule, nabasahan with increase in size, and then wider than tall, dapat benign ito. THYROID score, basa nito. THYROID score, THYROID score. Okay. So the rest of the nodules are cystic to complex, kaya THYROIDs 2, okay, or THYROIDs 3, okay. So on the left lobe, ganun din, maraming nodules. So iniisa-isa nila, THYROIDs 2, THYROIDs 3, and on, no? Okay. So ang conclusion nila is that normal size and multinodular thyroid gland with small vascularity, so a slight increase in the size of a few nodules, may konting increase, okay. Kaya this one is an incomplete report now. Kaya wala silang binanggit dun sa THYROIDs 4 and 5. When they put the notation of THYROIDs 4 and THYROIDs 4, okay. Kung may 5 pa rin, so needle biopsy is usually recommended. Pero ito walang sinabi, no? Okay, but in the report, it's mentioned there, THYROIDs 4, kaya nakakatakot na rin yun, no? Another patient, okay, ito, multiple nodules, okay, bawat nodules meron, no, description, THYROIDs 4, nakakatakot, okay, THYROIDs 4, another nodule, THYROIDs 3, THYROIDs 4, THYROIDs 5, so a combination of 3, 4, 5, dami, no, and then here on the left lobe, may THYROIDs 4, then THYROIDs 5, okay, so pinapa-biopsies to, okay. So biopsy, the biopsy was done on 2 nodules, A and B, right and left, okay? And then it's ang lumabas, most likely it's a adenoma, benign pa rin, no? Benign pa rin. So when he came to me, I suggested na you just observe, no? Okay, no need for an operation. My recommendations and advice in reading and interpreting ultrasound thyroid results. Number 1, remember that the results or diagnosis on the ultrasound given to you by the radiologist are not final. Until seen by a thyroid specialist clinician. Thyroid specialist clinician. Yung somebody whom you trust, whom you know how to interpret the results, and then also correlating your clinical findings. And then in the reports issued by the radiologist, there is usually a caveat or a statement to the patient receiving the reports, correlate clinically. Or specifically, the statement runs like this: this result is best interpreted by your attending physician in correlation with your clinical data, imaging, and laboratory results. I agree with this statement, pero dapat gawin, no? Okay, because a lot of times the clinician usually just follow the readings of the radiologist. Okay, so when you say clinical correlation, it just means that you gather all the other available medical data and information, such as the age, the sex, symptoms and signs, and other laboratory tests done to a particular test. Here we're talking about thyroid function tests and also the ultrasound, okay, to determine their reciprocal relationship and to establish an orderly connection through comparing mo yung mga data and contrasting them with the goal of coming out with a decision whether the patient has a particular diagnosis, which could be benign or malignant or what. Okay, so the goal is to come out with a clinical diagnosis that is as accurate as possible, not just based on the ultrasound results, but in combination with the other tests and other data. My other recommendations will be, you can take a look and read the contents if you want, natatakot ka, wag na lang. Okay? However, as a layperson, chances are you will not understand and more so interpret the narrative descriptions and conclusions of the certified reader. You will not be able to understand it. Okay? So have the narrative diagnostic reports read and interpreted by a trusted physician clinician or your attending physician, and let him or her make a decision on the report. The reason why I said that you have to mahirap na to interpret as a layperson, because even for us physician clinicians, we have to interpret the words and phrases used by the certified readers kasi wala namang standard statement yan. Maraming iba-ibang descriptions. And then a lot of times we have to read between the lines. Okay? And in addition, we have to correlate the findings and conclusions of the readers with the symptoms and signs. Okay? So which only doctors can do. Okay? Other tests and other circumstantial situations that the patient may have to make a decision whether, one, everything is normal, a finding that is mere baka konting variation lang, no? Normal pa rin yan, something abnormal that is being suspected, pwede, or there is really abnormality going on. So this is the decision that a clinician will have to do after correlating with the clinical findings. And at times, we have to check the accuracy of the reports. And we have to have discussion with the readers. Tama ba yung sinasabi ninyo? Baka mali. Bakit kulang yung report? Ganon, no? So, in the end, have the narrative reports, diagnostic reports, read and interpreted by a trusted physician clinicians. Okay? And then let him make a decision on the report. How I usually read and interpret the reports as a thyroid specialist, these are what I usually do. Number one, I read the reports and take note first of any red flags for cancer. Yan ang unang priority ko. Okay? So if there is a thyroid's conclusion, I take note of this first. If there are conclusions for possible cancer, like thyroids 4, 5, or even 3, okay, I then look at the narrative descriptions and study the basis for the radiologists making the conclusions. If the bases are valid, then I tentatively accept the conclusions after reading the report pa, okay? Tentatively because I still have to examine the patient's neck. I still have to correlate the reports with the physical findings as well as other data and information, such as other tests that could have been done on the patient and also the other data on the history. If there are uncertainties or incongruencies in the basis and in the reports, I examine the patient, particularly the neck, the thyroid, then make a decision, essentially whether to repeat the ultrasound in another institution to be read by another reader. So that this is a decision that I have to make. If the reports do not contain any red flag for cancer, again, just the same, I do scrutinize the reports to check for any incongruencies. And then I also examine the neck to correlate with the reports of my clinical findings, because there's such thing as false negative report on the ultrasound. So whatever be the report, whether there is a suspicion for cancer or not, I correlate clinically. I always examine the patient's neck, okay, which is a must for all thyroid specialists. There are some thyroid specialists who do not examine the neck, they just base it on the diagnostic report. Then I decide accordingly. Now, how radiologists read and write the reports, meaning what are the idiosyncrasies that they have? One, there are a lot of subjectivity in the radiologist's interpretation of the findings in the ultrasound. As a result, there are a lot of inter means two people, inter-observer variations, meaning given the same ultrasound plate, yung film, two different readers will read and interpret them differently. So that's the reason why I said there's a lot of subjectivity. Number two, idiosyncrasies. The thyroid is something recent in the Philippines. not all radiologists are adept in reporting thyroids. There is a lot of overreading based on my personal experience. Number 3, radiologists commonly put recommendations after their conclusions, especially when there's thyroids 4, thyroids 5. Examples of recommendations are tissue biopsy, follow-up ultrasound every 6 months, every 3 months, etc. My recommendation is just to consider them as personal recommendation from the radiologists. We cannot stop them from giving their personal recommendations. It's because it's a free country, democratic country. One does not have to follow them. Let your thyroid specialist decide on what to do next. The thyroid specialist may not also follow the recommendations of the radiologist. So remember their caveats when they put on the report. They ask the clinicians to correlate clinically. So that gives you the clinicians the leeway not to follow the recommendations. So to emphasize, again, personally, whatever be the report, I correlate clinically. My advice on what to do with the thyroid function test and ultrasound report. Okay, I will tackle this with a summary and also take away lessons. Okay. So I have discussed all of these topics, general recommendations, okay, and then how to read, interpret thyroid results, idiosyncrasies of radiologists, examples of challenges, and then my advice in reading. So although the reports are written for healthcare professionals, not patients, there is a lot to learn that you can learn by just looking, studying, and learning from them, especially after this pep talk. Okay, so somehow, although it's not easy to understand all this lecture, but somehow you'll get some idea and learn from it. So, but in the end, however, always have a trusted thyroid specialist clinician read and interpret the results for you. Learn how to palpate your own thyroid. Yung ganito, I've taught you that before, okay? Do regular thyroid self-examination. You may not need thyroid test if you do regular thyroid examinations. And then do the diagnostic test only when indicated, kung kailangan lang. So the indications are seen on the right side of the slide. But before that, if you do diagnostic tests outside the indications, you will most of the time, you will end up with a lot of false positive, alarming readings, which can cause undue anxiety, which may lead to other unnecessary tests like biopsy, which may lead to unnecessary operations, and not to say more expenses. So the indications for doing a diagnostic test in general will be you screen for a disease or exclude its presence in high-risk patients. And then you want to have a more definite diagnosis after clinical examination, okay? And then to determine the severity of the disease present and to project the outcome or prognosticate. And then lastly, you can do the lab exams to monitor the progress of the disease or the treatment. So at the end of the day, as I said, have a trusted thyroid specialist review and interpret and do a clinical correlations. And after hearing the explanations and recommendations on what to do next by your attending physicians, feel free to ask questions. Always ask questions as needed for further clarifications. The decision on what to do next should be a shared one between you and your attending physicians and not just dictated by your attending physicians. And then if there's a need for a second opinion for another physician on the conclusion and recommendations on what to do next, go ahead. You have the right to seek a second opinion. This is part of patient empowerment. Knowing the principles, the processes of reading and interpreting laboratory results, which I discussed today, and their associated caveats, the mga warning signs, is also a part of patient empowerment. So a takeaway in relation to patient empowerment, be always in touch with reliable medical information on how physicians read and interpret thyroid function tests and thyroid ultrasound. Knowledge is power, it gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, kapangyarihan, to gain greater control over decisions in medical management of oneself by having some idea, kahit na konti, some idea on how physicians read and interpret thyroid function tests and thyroid ultrasound. So with that, I end my pep talk. I hope I have empowered you to have a better understanding of the importance of reading and interpreting thyroid test results in your health management. Before we go to the QA session, so reminder, take the OLETE, also 50 OLETE certificates entitled 1 to the voucher. And then please write your comments for those who are not taking the, even for those who are taking the OLETE, you can write down your feedback here on the chat box. Okay. So with that, let's now have a group picture taking before we go to the question and answer sessions. Okay, ready? Get all set, pictures. 1, 1, 2, 3. Oh, may haba-haba. 1, 2, 3. Okay. The floor is now open for questions, comments, suggestions, recommendations, and also consultations if you want. Now,
Can I say some?
Sige, go ahead, Susan. Sige.
Yes, Doc. First of all, I should have attended this session 2 decades ago. You know why? I had a thyroid operation 1998 after consulting 3 doctors. And what happened is that the entire thyroid gland was removed. Because I think the doctor's findings was papillary carcinoma.
Okay.
I wasn't able to research earlier what papillary is all about, but anyway, I would presume that the papillary is
cancer. It's a cancer.
Yeah, papillary is a cancer, but papillary is part of the thyroid gland.
Yeah.
Okay.
When you say papillary cancer, it's a type of thyroid cancer.
Okay. So anyway, I underwent ROJoson, REI, and then since then I've been seeing endocrinologists. The last was a very busy endocrinologist from your hospital, so I left him after 3 years. Now I'm seeing another endocrinologist. Okay, my concern and question. I go to a regular doctor, and every 3 months, I undergo tests. The immunology, I have a copy, I undergo FT4 eclia. I don't know what eclia means, and STSH eclia. After he saw the results, apparently there is a warning in the result of TSH, it went beyond the range. He gave me he increased the
levothyroxine.
He increased that from 100 milligrams to 125 milligrams. So, well, at least I feel, I don't know, I feel better. I will see him again in September. So my concern is that I will go on seeing him. I will go on taking levothyroxine for life, right, Doc?
The second one, the answer to the second one is yes. The first one, I have to make a qualification. Okay, whether you have to see him Well,
What do you mean qualification?
I cannot answer you directly to the point because your first question is whether you have to see him all for the rest of your life.
Because every time I see him, he's now, of course, he is in a hospital here in Makati, no? Because every time I see him, of course, I have to show him the result of whatever test he asked me to undergo, and these are different. These are I should say more than 5 tests, no? Not only the thyroid test, but the FBS, CBC, what else? Of course, there are. So I usually, for the past 3 years, I've been seeing him, except during the pandemic, no? I've been seeing
Okay.
him at least 3 times a year.
Okay. Okay,
Okay.
I will just leave that question later on. Yung seeing your doctor on a permanent basis. Okay.
Okay.
So, number one, you have papillary thyroid cancer. Okay.
Yeah.
So that's a type of thyroid cancer now, which is usually slow growing. Okay. It's a good prognosis. So when was you operated? When were you operated?
1998.
1998. How many years na? For
More than 2 decades.
24 years already. Okay.
Yeah.
At what age? At what age were you operated on?
Siguro, wala pa yata akong 50.
Okay.
Oh.
Okay. Anyway, as I said, remember, papillary thyroid cancer is one of the 4 usual types of thyroid cancer. Okay, you have the follicular, medullary, and anaplastic. And papillary cancer is the best cancer to have if you have to have a thyroid cancer. Okay, it's at 24 years most likely baka hindi na uulit yon. Okay, 24 years.
Yes.
Okay, and then most likely, I'm not saying 100%. Okay. And then total thyroidectomy, tama, pwede. Okay. Especially if it involves the 2 lobes, 1 lobe or 2 lobes. Isang lobe.
Siguro, I didn't ask anymore that
Okay.
time. I was so
Anyway, okay.
anxious.
Pwede na. And then binigyan ka pa ng additional radioactive iodine therapy to reinforce it.
Yes.
Okay.
Yes.
So at 24 years after, now so wala kang recurrence. Okay, that's good. Congratulations. Number 2, pag tinanggal yung total buong thyroid mo, you usually end up with hypothyroid kasi wala ka ng thyroid, no? Okay? Wala ng thyroid gland to produce thyroid hormones. That's why you have to take your thyroid hormones for life. Okay, so tama yun, that you have to take it for life, no? Yung dosage now will be dependent on how tinatitrate lang naman yan, no? Tinatitrate, no? Kung what is the minimum level of minimum amount of thyroid hormones that you need to maintain you to a euthyroid, no? Okay.
Mm-hmm.
I said kanina, some endocrinologists use the TSH as parang pinaka main basis for saying whether it's hyper or hypothyroid, no? Pero kung minsan yung test na yung TSH yun, nagkakamali rin siya, no? Sa laboratory, no? Okay. So you just have to take note of that, no? Pero yung sa iyo, kung wala kang nararamdaman, probably 100, 124 years na, no? Kung 100, 1 tablet, 100 microgram probably will do. That's my personal opinion. Okay? So, then you don't have to take it every 3 months yung test na yun, no? So, yung thyroid function test, you don't have to take it every 3 months, no? As long as you don't feel anything, you just maintain it, no? Kasi you need it as a replacement. Okay? As a minimum measure, you have to take it as a replacement kasi wala ka ng thyroid hormones, no? Okay? So whether you have to go back to the doctors, it's really up to you because as I said, there are at least may mga ritualistic, maximalist, and minimalist, no? Okay? So there are some doctors who will give you a lot of tests, okay, nice to have, no, but are not really needed, no? Okay? So ibangga mo na lang yung personality mo with the doctor. If you are also a maximalist doctor, physician, patients that you want everything, edi baka vibes kayong dalawa.
Ganun ba yun? Because,
Kasi there are some patients who really want, despite the explanations that as a minimalist, I usually explain things that these are not really needed. Pero kung minsan, hindi be convinced, no? Okay?
no, I just listen to what he says, eh. And then afterwards, he will already write the prescription, and then what are the tests I should show, test results I should show him 3 months after.
Okay. So part of my patient empowerment program is that you have the kapangyarihan to ask. Okay? Ask questions. Okay? do not just follow. No? Okay? If you just follow, pagkatapos sabi yung doctor, gustong-gusto itong pasyente, maraming test. Sige, pagawa na natin para masaya siya.
Naubos na yung pera ko, Dok.
Kaya nga, you should have conversation.
Retired pa naman ako.
Okay.
Anyway,
So,
sige, thank you.
So you make a decision whether you want to change to a minimalist or a maximal, or maintain the maximalist doctor.
I like that classification. Okay, thank you.
Okay. Okay,
Sige.
any more questions? Okay. Any more questions? Do I see, where is it? Ladies, any questions on the chat box?
Wala, Doc, wala sa chat box.
Okay.
There are no questions sa chat box.
Okay. So, I suppose I can see 1, 2, 3, 1, 2, 3, 4. About 5 of you present here have experience with thyroid. I won't mention the names. So you have all experience with thyroid. You want to ask questions?
Doc, ask ako ng question.
Sino to? Perla. Okay, Perla. Yeah. Okay.
Yes, Doctor, yes. Kasi last month, nagpunta ako sa dentist. Magpabunot sana ako ng ipin. Ayaw niya po akong bunutan kasi nga umiinom ako ng gamot sa thyroid. Magkuma daw muna ako ng clearance sa aking endocrinologist. Bakit po ganun, Doktor? Kukuha ako ng clearance pa. Kasi daw yung anesthesia, parang meron yata sa, sabi niya sa anesthesia, parang meron daw siyang contents na nakakapalpitate ba yun? O ano?
Anong anesthesia? Yung gamot na ibibigay sa'yo?
O yung anesthesia, Doktor, di ba pag binunutan ka, may tuturukan ka ng anesthesia. Eh parang nakakaano daw sa thyroid daw yun. Opo. Hindi pa ako nakakakuha ng clearance.
Paano mo, how do you like me to answer your questions?
Oo. Sabi niya,
yung mga dentists are just like some other doctors who are too specialized. Hindi sila holistic, na hindi nila alam yung ibang sistema sa pasyente, no? Example, probably isang specialist who treat on the eyes, lahat ng kung magpapa-opera ka, gano'n, papa-clearance ka lahat. Hindi nila maintindihan kung may heart disease o gano'n. Basta lahat may clearance. Yan tinatawag na clearance, di ba? So, isa dentist, gano'n din, no? So, yung ibang dentist, hindi naman nangangailangan. So, they just go ahead because through experience, wala namang masyadong side effect yung levothyroxine mo with the anesthesia.
O yun nga po daw, yung ininom ko na gamot baka may sa anesthesia.
Okay. So yun. So it all depends on the dentist that you're seeing. As I said, we classify these people into maximalist or ritualistic. Yung iba, dekahon na lang. Basta pag meron kang gamot ni inom, kailangan meron kang clearance. Di ba? Okay. Parang doon sa COVID vaccination, bago ka pagpa-vaccinate, pinapa-clearance ka muna, no? May medical certificate, no? Pero usually hindi na kailangan yan di ba? Ganon, no? Okay. So, it all depends on the doctors that you're seeing, kung ano yung mindset nila. May mga doctors na hindi nagpapaano na? Okay.
Ay, natakot tuloy ako magpabunot kasi baka mamaya pag tinurukan ako ng anesthesia, baka mamaya ako kasi ayaw naman niya akong bunutan, Doktor, pag wala akong clearance.
Jadi pumunta ka sa isang doctor to get a clearance. Okay, I do a lot of these things also. That's why I said, yung mga hindi kailangan, pupunta rin sa akin, I cannot refuse them. So I give them the clearance, di ba? Parang gano'n, madaming gumagawa ng thyroid test, hindi mo kailangan, pero nagpapagawa. Pagkatapos, pag may alarming results, pupunta sa akin. So, mabasahin ko naman, di ba? Okay. So if you cannot shift to another dentist, then you might as well get the clearance kung kailangan punutin ka na ng ngipin mo. No? Okay.
Okay, doktor.
You can see me if you want. Walang problema. No?
Kayo na lang kay doktor. Kukuha. Ano bang gagawin, doktor, pag kumuha ko ng clearance? Mayroon ba ang mga series of tests? Ganon? Well,
Di ba sabi ko sa iyo, history and physical examination is yung pinaka-minimum. Wala na mga test.
opo.
Wala. Sabi sa iyo, ang dami tayong di ba? Ang daming naniniwala sa mga test pa. Kaya sabi ko, Susan, sabi ko marami tayong maximalist patients. Maximalist patients. But you're influenced by the maximalist doctors.
Okay po, doktor.
Okay.
Okay, doktor.
Doc, may questions, Doc, sa chat box. Si Rochelle de la Cruz.
Okay.
Hi, Doc. Question po. From my recent test, normal F3 and F4, slightly elevated ang TSH. What are the symptoms to watch out for para po malaman ko whether I should undergo further test?
Number one, okay. Are you taking medicine, Rochelle?
Hindi po, Doc. Wala po akong iniinom.
Wala, okay. So slightly elevated, okay. Number one, when you say slightly elevated, I have to look at the figure and the number, no? Okay. And then, as I said, kung slightly elevated, mga endocrinologists will tell you that you have hypothyroid. Okay? Elevated kasi TSH, no? That's how but ako, baka kung wala ka namang symptoms, I can ask you to repeat it, no? Para kampante ka na, no? Yung lumabas ay normal, wala na. We're not talking about, kasi nangyari din sa akin yan in 2017, okay? When I was about to go abroad, my wife asked me to have a test. Okay, so my T4 was normal, my TSH was elevated. So pinaulit ko after 1 week normal. So I don't have to take any test. So normal pala, no? Okay. So if I just rely on one test, somebody if I see an endocrinologist sabihin niya sa akin, hypothyroid ka, Ray, uminom ka na ng gamot, no? Okay. So, but ako, I did not take the medicine. So, but if you don't want to take the test, if you want to watch out for symptoms, no, you watch out for symptoms of hypothyroidism, but which is not very common, which usually mahirap makita rin yun, no? Okay. Kasi kung yung full-blown na hypothyroid, sinasabi, palaging nanghihina, laging drowsy, laging naantok, no? Mabagal tumilos, no? Bihirang-bihira naman yun because there are other causes for that, diba? Maka stress, no? So if you want, pari-check mo na lang, no? Kung normal na yon, okay na yon. So you don't have to do anything extra, no? Okay.
Another question, Doc, from Jacqueline Tong. What carries more weight, the T3 or T4?
At the moment, they said that the T4 is more reliable than T3. Okay. So, in mga konti lang instances na talagang you put importance on the T3. No? Okay. Kasi yung mga thyroid hormones, nako-convert lahat sa T4 yung mga nagsi-circulate sa body. No? Okay. So we usually put more weight sa T4, no? Okay. That's why when I order for tests, no, I don't usually order for the 3 tests anymore. No, dalawa lang, FT4, TSH, no? Okay. If I have to order, no? Okay, para makatipid ng another, probably 600, 700 pesos yan. I don't know how much ngayon na. Baka 1,000 na ngayon. Na?
Doc, so a basic test, for example, for somebody who would like to find out about the thyroid situation of her body would be T4 and TSH. Okay na yan?
Pwede na. Pwede na. Plus yung symptoms.
Okay.
Dagdag mo na yung symptoms. Kung wala namang symptoms, no? Okay, symptoms of hyperthyroidism, no? Or hypothyroidism. Kung normal lang T4, TSH, okay na yan.
Okay. Thank you.
Okay. Any more?
Wala na, Doc. No more. No more
Okay.
questions.
Oh, I have another question.
Sure, Jackie.
Yeah. How do we, is there any way of preventing problems with the thyroid? Like kami, how do we try to prevent getting problems with thyroid? Is there any way at all?
In general, there is no way in general, okay, whether it's thyroid or other organs, no. The only disease that I know of offhand will be yung mga infectious diseases like COVID, no. You can prevent it, you can try to prevent. But other than that, let's say yung mga cancer, autoimmune disease, yung mga benign cysts, no? Ganon. There's really no way of preventing it, no? Okay.
Okay.
So just hope and pray that you don't get a bad case of a disease, no? Okay. So
Okay.
that's the reality of life. Sorry. Wala tayong magagawa. Ako rin hindi ko ma-predict anong tatama, anong tatapos sa akin, no? Ganon din sa thyroid. Kasi sa thyroid, hyperthyroidism, ano rin yan autoimmune, kadalasan autoimmune disease which is hard to prevent, no? Minsan sabihin nila stress-induced, bihira. Pwedeng stress, no? Okay. Hypothyroid, baka yun, baka kung kulang ang iodine mo, no? Okay. But usually we have enough iodine in our diet, no? Okay. And aging can also cause hypothyroid, di ba? Kung aging, no? Okay. Pero wala kang magagawa dun sa aging, di ba? So thyroid cancer, wala. We don't, except for just avoid exposure to radiation, yung mga excessive radiation, di ba? Kasi parang doon sa Japan, Hiroshima, di ba? Because of the nuclear explosion noon, daming may thyroid cancer because of the nuclear.
Okay.
But other than that, wala. I don't think, just hope and pray na lang.
It's not you're not predisposed. It's not hereditary.
So, kuminsan may mga diseases like medullary carcinoma, pwede, no? Pero bihirang-bihira. Saka it's number one, number two, it's also bihira sa Pilipinas, in medullary. Mas common sa US na. Okay.
I see. Okay, thank you.
Doc, may I ask something again?
Sure.
You were saying about avoiding radiation. After my operation, thyroidectomy, radiation yung inanok sa akin, REI.
Oh, okay. So when lahat ng gamutan may risk, may benefit and the risk, okay? So we just balance it, no? Okay? So kung ang mas malaki ang benefit in terms of avoiding a recurrence, no? Go for it, no? Okay? Yung risk of radiation is probably small lang yon kasi ilang session lang yon, 2 sessions, 1 session, pinainom ka 3 days.
Yeah.
Okay?
Then
So,
pinabalik ako uli.
yun.
Tapos, nung pinainom ako, 5 days ako sa hospital.
Okay. Kalkulado na yon kasi compared to yung sa nuclear, yung palaging, let's say history-wise, yung mga bata noon, mga centuries ago, niraradiate yan with, kung may tonsillitis, ang gamutan yon niraradiate, no? So that's why there was a high incidence of thyroid cancer. Kasi radiate and radiate, no? Pero nowadays, we don't use that anymore. Okay? Okay. The other example is sabi ko, yung nuclear bomb, di ba? Okay. Okay.
Okay, thank you.
So i-balance lang benefit risk. Na? Okay. Okay. Any more? There are no more questions. Last call.
Sure.
Raise hands. Aida is raising your hands.
Yes po, Doc.
Anong question mo?
Doc, hinahanap ko yung link test ni ni Mrs. Olivia Taylor. Hindi ko makita eh. Okay. So, kasi po noon, naka 300 microgram siya ng thyroxine.
Okay.
Tapos, gusto po niya talaga, iniintay kayong mag-clinic para daw gusto niya may kapa.
Ay, may
Hinahanap
clinic
niya
na.
yung pag-
May clinic na ako, di ba?
Okay po. Regular na?
Hindi. Once a week.
O yung mag-ano pa po? Yung mag-prepare po?
Appointment.
Appointment po. Okay po.
August 2. August 2. My next clinic is August 2.
Okay po. Sige po.
Meron pa akong one slot available. Last slot.
Okay.
Grab
Sabihin
mo
ko
na.
po sa kanya.
Once a week lang ako nagki-clinic. Na.
Okay po.
Okay.
Hintayin ko lang po pag nakapost yung schedule po.
Naka-post na. I'll give it to you, ma'am.
Okay. Okay po.
Okay.
Ano
Any more?
po? I think, medyo lumabas lang ako, Dok eh. Hindi ko na, kung natanong siya. Okay po. Ang high po is mababa ang TSH. Ang hyper pala. Paano po yung medication ng thyroxine? I-increase o i-decrease?
Anong i-decrease?
Yung pong gamot, halimbawa, kung mag-50 microgram ka or the usual 100 microgram.
Hindi. Okay. Ganun yun, ha? Okay. Let me spend some time. Ito yung, nakita mo yung drawing ko?
Apa.
Ito yung thyroid gland. So it produces T4, T3. Yan ang hormones, no?
Okay po.
So ito maraming, kung nasa blood siya, maraming form yon, whether it's combined to protein or free. No? May free, yung F nyo is free T4. No? Okay? So, and then, yung sa brain natin, no, pituitary, nagpo-produce ng TSH, no? Thyroid stimulating hormones, no? So, which means, itong substance nito, ini-stimulate yung thyroid gland to produce this T3, T4, no? Okay? So, kung normal ito, di ba? Kung normal yan. Pero kung mataas ito, okay, mataas yung T4 mo, tendency, kasi may auto-regulatory mechanism eh. So, tendency, bababa ito. Di ba? Para konti lang i-produce noon. No? That's why when you have T4 na elevated and then TSH depressed, you call that hyperthyroidism. Di ba? Hyper. So that explain bakit baliktad, di ba? Bakit mababa ito, bakit mataas ito, no?
Okay.
Now, kung yung T4 naman is mababa, no? Okay? Masyadong mababa, ang tendency for the TSH tataas. Di ba? Okay?
Okay, hypo.
May konting auto-regulation siya, di ba? So T4 mababa. So tendency is this one to produce more TSH para to ask this thyroid, kaya mag-overtime kayo, gumawa pa kayo ng T4. Kulang pa eh, di ba? Okay. So ito yung hypo. Okay. So ang gamutan nito magkaiba yung gamot, na? Okay. Ang gamot nito dito hyper, you call it anti-thyroid, no? Anti-thyroid gland, no? Panlaban, no? Okay. Dito naman, replacement ito. Okay? So replacement ito, hypo, kulang di ba? So magdadagdag ka, replace, o kaya add, no? Ang gamot ito, levothyroxine, i-add, no? So ang gamot ito is mga levothyroxine ito. Levothyroxine, no? So depending sa titration na yan, kung minsan kulang, kung minsan marami, dinadagdag-dagdag, no? Okay. Dito naman, iba yon. Ito yung mga tapasol, PTU, no? Iba yung gamot nito, no? PTU, tapasol, no? Okay. So I hope everybody understand now bakit ang results sa thyroid function test kanina sinabi ko, mataas ito, mababa ito. That's for hyper. Sa hypo naman, mababa ito, mataas yung TSH mo, no? So that's the explanation for that for those values, no? Okay. So yung sa pasyente mo kamo kung kulang yung T4 niya, okay, or mataas ang TSH niya, dadagdagan ito, no? So it can be 50, depende sa pasyente, no? 50, 150, 75, pwede rin, no? 100, ganito, 150, depende, no? Okay. So the other use for this levothyroxine, aside from the pangdagdag from replace, kunisan, sinusuppress, gamot used to suppress yung mga nodules, no? Suppress. Kasi pag binigay mo ng thyroid hormones, tataas yung T4 mo, di ba? Artificially. So pag tinaas mo yung T4 mo, bababa ito. And then, baka yung nodule nito, kumisan liliit siya. Kasi tumataas ito, di ba? TSH. Ay, ano, no? Okay. Pag bumababa, di ba? Pag levothyroxine, dinagdag mo ito to high level, bababa ito. So, kumisan nagsishrink ito, liliit, no? That's why for that patient that you mentioned, I was giving her 300, di ba? 300. So, titingnan natin kung lumit na, pwede nang unti-unti bawasan. Okay.
Okay po, clear po. Thank you, Doc.
Okay.
One thing pa po, Doc. Why, ano po ang times parang nire-relate ang hormonal imbalance sa depression?
Sa depression?
Sa depression.
Nako, marami yun. Maraming causes din ng depression, not only hormonal imbalance.
But how about hormonal imbalance?
Well, how do you explain that? A lot of causes for depression. Diba? Kumisan, may mga...
Hindi mo po ba pag may thyroid problem, minsan may mood swing?
Yeah, meron din. Pero kumisan, kadalasan, whether that patient is genetically predisposed. Iba kasi may mga inherent na personality na talagang depression. May personality na depression, di ba? Okay. So, then the other, yung hormonal imbalance can just parang reinforce lang. Mag-add lang doon siya doon. No? Okay. Okay. So, mahirap iwala yung dalawa. No? Mahirap. No? Okay. So you look first for the cause of the depression, whether it's psychological or kung may dahil sa gamot. Dahil kung saan sa gamot can cause depression o kaya hormonal imbalance, no? Kung kulang sa thyroid hormones, gano'n, no? Gano'n. Pero bihirang-bihira yun. Get it?
Okay po. Thank you so much po, Doc. Hindi po kanina po, yung may tanong sa magpapabunot ng ngipin, kailangan po medical clearance. Sinabihan din po ako ng dentist ko, pero hindi po dahil sa thyroid problem, dahil po sa hypertension. Kasi may maintenance ako.
Maraming
Hindi naman po, hindi,
Ah.
hindi naman po consider nung dentist. May maintenance ako sa thyroid. Mas ano po sila doon sa sa maintenance sa hypertension.
Oo nga.
Kaya
So,
hinihingi ko ng uh,
It all
medical clearance. Lalo na po sa senior.
it all depends on the dentist, how
Opo.
brave they are, how experienced they are. No?
Mhm.
Okay. Parang ako, I don't order for a lot of clearances before operations because of my, number one, I know it's not really needed. Number two, because of my experience, wala naman nangyayari, di ba? Basta I do pinaka-minimum na examination na evaluate kita, examine kita, do history, physical examinations. Kung sa palagay ko, wala namang risk for the complications, hindi na kita pinapa-cardiac clearance, di ba? Ganun.
Mhm.
So, but there are a lot of doctors who still go for clearance, no? Okay.
Okay po, para sure sila.
Oo.
Safe pala.
Maximalist, tawag na maximalist, di ba?
Oo, maximalist po.
Okay.
Thank you po, Doc.
Okay. If there are no more questions, Dana, let's call it a day. So next time, next Saturday, I might give a talk on medical records. Medical records. No? So itong tatlong sessions nito, past sessions, we're talking about diagnostic tests, di ba? So I suppose tama na yon, no? Tama na yung exposure na yon. Now we will be talking about medical records, no? How to generate, how to keep, and how to archive. No? Importante kasi yung medical records ng mga tao. No? You have to keep your medical records. No? Parang Susan, yung medical records mo, I hope kompleto yan. 1998 up to now.
Hindi. Tinapon ko na yung iba.
Importante yung mga records ninyo. Ha?
Patay
Okay.
ka.
Keep it for life hanggang kamatayan yung mga records yan. Parang land title yan.
Ako po, Doc, nakatago yung parang no remission.
Yeah. Sige, kaya I want to talk about it because number one, a lot of you do not keep your records. Number two, doctors do not get your records also, di ba? Di ba? Pagpunta kayo sa clinic, pag binigay niyo yung pakita niyo isang lab results, nako, hindi mo, pag uwi mo, wala na yung isang records mo. Tama? Okay. So I want to advise you to do it properly. No? Medical
Okay,
records.
Doc. Very nice topic next week.
Something to look forward to.
Okay. Sige, kung wala na, let's call it a day. Okay.
Thank
Thank
you,
you
Doc.
po.
Thank you, Doc.
God
Bye-bye.
bless po.
God
Thank
bless.
you.
Thank you po,
Thank
Dr.
you, Doc. Thank you
Bye.
so much.